Good afternoon, students. I hope you all had your lunch. Yes, and I hope it's not a heavy lunch, otherwise, you would fall asleep. Okay, so what's this? Who is he? You can recognize him. Yes, he's Mr. Bean. Okay, and what is happening to Mr. Bean? He's getting shocked. Something. Okay, he's saying something and getting shocked about it. So, topic for me today is shock. Last class we have covered hyperemia, congestion, and edema. Hope all of you have read about it. Yes? Okay. So, definition of shock. As always, I keep repeating in all the classes, especially general pathology, you are supposed to know the definitions of shock and definitions of edema, gangrene, hypertrophy, hyperplasia. Because in the afternoon orals, when you come around to all the four examiners, you will be having four stations. One will be general pathology, one will be clinical, one will be first systemic, the other will be second systemic. Systemics will have the gross specimens, and the general pathology will have the gross specimens, the clinical pathology will have the instruments. So when you come to general and systemic, you will be asked about all the definitions. So make a list of all these definitions and memorize them. Otherwise, you will miss some words. Okay. What is definition of shock? It is defined as a clinical state of cardiovascular collapse due to sudden decrease in cardiac output or reduction in circulating blood volume, giving rise to systemic hypoperfusion with consequent tissue hypoperfusion, hypoxia, and injury. It's quite a big definition, okay? But if you split it up, it's quite easy. It's a clinical state. It's not a pathological state or a metabolical state. It's a clinical state of cardiovascular collapse. Cardiovascular system collapses because there is sudden decrease in cardiac output or reduction in circulating blood volume. It gives rise to systemic hypoperfusion. Because of systemic hypoperfusion, there is tissue hypoperfusion. Because of this, there is hypoxia and injury. So the keywords are clinical state, cardiovascular collapse, decrease in cardiac output, reduction in circulating blood volume, systemic hypoperfusion, consequent tissue hypoperfusion, hypoxia, and injury. Hope you got it. What are the types of shock? This usually it is given as a 6 marks bit. Okay, like a short question or very short. So depending on it is given as a 6 marks or a 3 marks, you have to modify your answers. Okay. So types of shock are cardiogenic shock, hypovolemic shock, septic shock, which is again endotoxic shock, exotoxic shock, neurogenic shock, anaphylactic shock. So cardiogenic shock. What is this organ here? This is the heart. Is it happy? It's unhappy. So what is cardiogenic shock? Myocardial infarction and myocarditis, ventricular arrhythmias, cardiac tamponade, pulmonary embolism. So just remember these four. We will go into each later on when I'm dealing with the cardiovascular system. Hypovolemic, massive acute blood loss. Usually it happens when there is a trauma, severe burns and trauma, vomitings and diarrhea. Sudden vomiting, severe diarrhea, there is hypovolemia. Okay. Neurogenic shock. It can happen in spinal shock during anesthesia, spinal cord injury, and anaphylactic shock where there is mismatched blood transfusions, hypersensitivity to drugs, and certain venoms. Okay, these are all anaphylactic shocks. These have to be dealt. All the stages of shock, all the types of shocks have to be dealt with very fast. Septic shock, systemic microbial infections like gram-negative bacteria, gram-positive bacteria, or fungal infections. Okay. What is the pathogenesis of septic shock? A septic shock can be given as an essay question. Okay. They'll give you some history and then they'll ask you what is the diagnosis, define shock, what are the causes, types of shock. So when you get septic shock, you're also expected to write about shock, definition, types of shock, and then go to the pathogenesis of septic shock. So, life support procedures like What are the life support procedures? It could be dialysis, it could be a pacemaker, increasing invasive procedures, immunocompromised patients, chemotherapy, immunosuppression, HIV infection, and spread of localized infections. So, life support procedures, increasing invasive procedures, immunocompromised patients on chemotherapy, immunosuppression, or HIV infection, spread of localized infections. What localized infections? Like any cut, any mosquito bite also can lead localized infections. So now we'll talk a little about lipopolysaccharide quantities. Why are these lipopolysaccharide quantities coming into play now? So we want to see what stage it is, release of this. So low, moderate, high. So low monocyte macrophage activation, endothelial cell activation, complement C3a, C5a, local inflammation. So we'll go from below. There is local inflammation, complement C3a, C5a, endothelial cell activation, and monocytes and macrophages are activated. In moderate, systemic effects, acute phase reactants, and fever. When there are high lipopolysaccharide quantities, it goes into shock, low peripheral resistance, there is hypertension, DIC, ARDS, and low cardiac output. So at this stage, it is a very, very dangerous stage. The patient can die. So, what is a cytokine cascade in sepsis? So, horizontally, this is a time, this is a plasma levels of the lipopolysaccharides, tumor necrosis factor, interleukin 1, interleukin 6, interleukin 8. So, lipopolysaccharides are rising and falling quickly. Tumor necrosis factor a little slowly, not so high, for taking some time. Interleukin 1 is rising, not so high, taking a little time. Interleukin 6 and 8 are rising later on, slowly, going up to little levels only, but later taking almost up till 10 days. So if we look at the blood at this stage, only these will be elevated. Okay. There is a toxic shock syndrome, which is a group of bacterial antigens which are known as super antigens. Okay, normal antigens are okay. These are bacterial antigens which are known as super antigens produced by staphylococci. This you will come across also in microbiology. Okay, toxic shock syndrome toxin one. This is known as it activates a polyclonal T lymphocyte. There are two lymphocytes, B lymphocyte and T lymphocyte. Here, the polyclonal T lymphocyte is activated, which induces systemic inflammatory cytokine cascades, leading to septic shock. There is diffuse rash, vasodilation, hypotension, and shock. So, what are the stages of shock? As I said, it can come as an essay question or it can come a split up like. So, you may just be given stages of septic shock. Okay. So, non progressive phase, progressive phase, irreversible stage. One is non progressive, progressive, irreversible. Here it is irreversible. So let us first start non-progressive phase. This is depends on the neurohumoral mechanisms, baroreceptor reflexes, release of catecholamines, which activate the renin-angiotensin axis, antidiuretic hormone release, and generalized sympathetic stimulation, leading to tachycardia, peripheral vasoconstriction, and renal conservation of the fluid. Now we come to the progressive phase. There is widespread tissue hypoxia, anaerobic glycolysis, excessive production of lactic acid. This point you have to remember, it's important. Lactic acid, excessive production, which leads to lactic acidosis. Because of acidosis, there is decreased tissue pH and there is blunting of vasomotor response, peripheral pooling, and decreased cardiac output. Yes, this is alarming. At this stage, now it has become alarming. It is going to progress to which stage? Irreversible stage. Okay. This is the irreversible stage. At this stage, anoxic endothelial cell injury has occurred. Disseminated intravascular coagulation occurs, widespread tissue anoxia occurs, lysosomal enzyme leakage with aggravation of shock and complete renal shutdown. Wherever we come across a very serious case of shock or wherever there is a case of septicemia, remember this point, complete renal shutdown. Once the renal shutdown occurs, where there is anuria, where there is absence of urine, so patient is going to die. Now we go into the morphology. Brain, there is ischemic encephalopathy. Heart, myocardial infarction, subendocardial hemorrhage, contraction band necrosis, and kidneys, acute tubular necrosis. So brain, ischemic encephalopathy, heart, myocardial infarction, subendocardial hemorrhage, contraction band necrosis, and kidneys, acute tubular necrosis. Adrenals, cortical cell lipid depletion, liver, central hemorrhagic necrosis, and fatty change. GIT, there is hemorrhagic entropathy. Lung, there is shock lung, which is also known as ARDS, acute respiratory distress syndrome. We'll go into it shortly. Shock lung is an expected question, and when it comes, it's easy to write because the term is self explanatory. It's lung and it has resulted because of shock. Okay, so it's characterized clinically by rapid onset of severe life threatening respiratory insufficiency, cyanosis, severe arterial hypoxemia, refractory to oxygen therapy, progresses to extrapulmonary multi-system organ failure. So, rapid onset of severe life threatening respiratory insufficiency. Just imagine that if you close your nose and mouth for a while, just imagine you would feel threatened, like you feel breathless. And here, the patient has severe life threatening respiratory insufficiency. Because of lack of oxygen, there is cyanosis, severe arterial hypoxemia, which is refractory to oxygen therapy. My God, see, the patient is having hypoxemia and we try to give oxygen, it is refractory. And this slowly progresses to extrapulmonary multi-system organ failure. Organ failure, multi-system organ failure, definitely the patient is severely sick. What are the synonyms for the shock lung? In the exam, they may be giving you in any term. One is acute respiratory distress syndrome. Next is DAD, diffuse alveolar damage, acute lung injury, traumatic wet lungs, post traumatic respiratory insufficiency. These synonyms can also come as a PG entrance or NEET entrance bit. Which of the following is not a term used for shock lung? So, most commonly we use ARTS. So, shock lung, what is it here? Now, let us see. There are certain injurious factors which are affecting the lung. There is damage to the alveolar capillary walls with injury to the endothelial and epithelial cells, interstitial and alveolar edema with hyaline membrane formation, and pulmonary edema, stiff lung. Okay, this is important. Again, here, what is important is apart from the damage, injury to endothelial and epithelial cells, interstitial alveolar damage, edema, hyaline membrane. Why should this hyaline membrane form in the lung, which has to nicely inflate with each breath of air which we take? Membrane has no business to settle down there. Okay. So, morphology heavy, firm, red, and boggy lungs. So, lungs have become heavy, they have become firm, they have become red and boggy. Congested blood vessels in the interstitial, interstitial and intraalveolar edema, acute inflammatory cell infiltrates. What are the acute inflammatory cells you know of? Yes, they are neutrophils and monocytes, sometimes eosinophils if there is a parasitic infestation, and the chronic inflammatory cells are the lymphocytes. These macrophages are they hover in between. They are like scavenger cells. So wherever there's some debris, they come and greedily eat it up. Okay. Then there is fibrin deposition and alveolar walls lined by waxy hyaline membranes. This is important. Hyaline membrane. It's also known as, that's the reason, hyaline membrane disease. Can you see? Have a look at this. These are the normal lungs. This is the normal alveoli. Can you look at the normal alveoli? Look at the ARDS. What's happened to the alveoli? They have become constricted, and you can see that there is some deposition, this green deposition here. Okay. So here you can see that there is heavy, boggy lung, And you can see that there is a pink hyaline membrane. Okay, these are all the alveolar spaces along with the acute inflammatory cells, and you can see that there is widening of the alveolar spaces. Yes, same picture. Again, I put for you to appreciate the hyaline membrane. This can be stained by a special stain known as periodic acid shift stain, which is a PAS stain. Okay, periodic acid shift stain. Those of you who are aiming to get good marks and maybe a first class and a distinction, try to also learn the special stains as you go ahead. Okay, each system has some special stains. Make a list of all the special stains and memorize them. Or memorization is the only way out so that you write correctly. And always I tell you, you have to draw pictures and you have to draw flowcharts because nobody is going to read each word to word of what you have written. So side headings are important and a very good, neat handwriting is important, and writing each question on a separate paper is important. Don't jumble up because you will be given adequate number of pages. So each question you start writing on separate paper. Okay, and these are just some tips which I give. So what are these sketches known as? This picture, what is this? These are known as thumbnail sketches. Okay, these are very easy to draw, and these are the stages of shock. Okay, this is a person. What is this organ? Yes, this is a heart. Okay, hale and healthy, nicely, meme, obviously singing, dancing. Something is happening to the heart. So, this is stage one. This is known as compensated shock. At this stage, if we correct whatever was happening to him, he can be brought back. Stage two is a decompensated, progressive, hypotensive shock. So, you can see that he's sweating, he is become clammy, he is not able to stand. Stage three, he's down, his eyes are closed. Okay. Here they are half open, open eyes, smart and happy. Stage three, it is irreversible shock. Heart is not beating, stop beating, and obviously the patient is dead. What are the clinical features? So, signs of hypovolemic shock, weak and rapid pulse, tachypnea, cool and clammy skin. The minute, suppose tomorrow you're going to do internship or you're going to do PG, you're going to practice tomorrow, suddenly a patient comes and a cool and clammy skin and a weak and rapid pulse. Pulse is weak but rapid and tachypnea, breathing very fast. So suspect hypovolemic shock. Okay. Signs of septic shock, clinical features are related to organ involved. Finally, renal failure. So irreversible stage, decrease in myocardial contraction due to synthesis of nitrous oxide. Ischemia of intestine allows intestinal bacterial flora to enter the circulation. Again, the bacterial flora are not supposed to enter the circulation because there is ischemia, it breaks down, it lets the bacterial flora to enter the blood circulation. And what happens? Blood should not be invaded by the bacterial flora. So endotoxic shock is superimposed, complete renal shutdown due to acute tubular necrosis. Okay. If low perfusion states persist, irreversible and death is imminent. Remember, tomorrow in your career, whenever, whichever subject you're going to do post graduation and specialize and practice, shock is something which has to be looked into immediately. When you see a patient with cold and clammy skin and a rapid pulse and a weak pulse, immediately record his BP and see at which stage of shock he is in. And it has to be attended immediately. What is morphology of shock? This is hypoxic injury to cells and tissues and failure of multiple organ systems, most evident in um, brain, heart, kidneys, and adrenal and GIT. So, brain. So, hypoxic injury to cells and tissues. So, failure of multiple organs. Which are these multiple organs? They're brain, heart, the kidneys, adrenal, and GIT. Brain undergoes ischemic encephalopathy. Heart undergoes focal or widespread coagulative necrosis. there is subendocardial hemorrhage and contraction band necrosis. So, what organ is this? Anybody can say? This is heart muscle. Okay. So, what happens to the heart? There is coagulative necrosis. You can tell what are all the types of necrosis. This is often asked question, and you're supposed to know the answer. Okay. So, now, kidney, I said acute tubular necrosis, morphologically destruction of tubular epithelial cells, and clinically acute loss of renal function. When there is a renal function loss, it leads to oliguria, anuria, electrolyte imbalances, and they lead to acute renal failure. So, if you look, there is acute tubular necrosis, and there is destruction of the tubular epithelial cells. Also, often you are asked what is origin of a renal cell carcinoma. So, some of you say glomeruli, some say tubular cell. It is nothing but tubular cell. Okay, tubular epithelial cell. So now we'll come to the microscopy. So there is focal tubular necrosis at multiple points of nephron. Can you just tell me what are all these structures? This is the glomerulus, okay? Tubules, vessels, this is stroma. So focal tubular necrosis at multiple points of nephron. It's skip area. See, they are involved here. There is necrosis. Some are free, some are nice, healthy. Rupture of basement membrane. There are hyaline casts, tan-Harsfall protein, hemoglobin, myoglobin, and other plasma proteins. So this tan-Harsfall protein can be given as PG entrance bit. So what is it? Tan-Harsfall protein. It can be given as a PG entrance. Where is it found? Okay. Accumulation of leukocytes in dilated blood vessels. Can you look at the blood vessel here? Yes. This is again a blood vessel. Regenerative changes occur if survival occurs. So, what is the morphology of shock in gastrointestinal tract? Patchy mucosal hemorrhages and necrosis. Okay, patchy mucosal hemorrhages and necrosis. This is a mucosa of the bowel. Okay, so it leads to hemorrhagic enteropathy. Liver, fatty change. Can you see the fatty change here? And central hemorrhagic necrosis. This is a central vein. Dilated central vein with central hemorrhagic necrosis. Remember, whenever there is central hemorrhagic necrosis, the hepatocytes undergo dropout, dropout necrosis. And the periphery hepatocytes undergo fatty change. So, now let us look at the body as a whole. Okay, brain, hypoxic encephalopathy, 7%. Hypoxic encephalopathy. In the pituitary, there is hemorrhage and necrosis in 5% of the cases. In the lungs, ARDS. Can anybody tell me what is the full form of ARDS? Yes. Yeah. Acute respiratory distress syndrome. This is 50%. Look at it. This is major, major. And then we'll go to the heart. There is necrosis, which occurs in 36%. And liver, there is hypoxic damage, again 50%. And in the gut, there is enterocolitis, 26%. In the pancreas, there is necrosis, 6%. In the adrenals, there is hemorrhage, 14%. And in the kidneys, acute tubular necrosis, which is 22%. So, the majority are seen in lungs, acute respiratory distress syndrome, 50%. And liver, hypoxic damage, 50%. And next, followed by heart necrosis 36%, followed by gut enterocolitis 26%. Yes, adrenals hemorrhage 14%. Yeah, I forgot about the kidneys. So after the gut, the kidneys which go into acute tubular necrosis, they are 22%. So again, first will be the lungs and the liver, and then yeah, 36% heart, and then gut 26%, and then the kidneys 22%, and the adrenals. Okay. Prognosis depends on the cause of shock. What is it caused due to? So, shock is precipitated by MI, myocardial infarction, severe hemorrhage, and uncontrolled bacterial sepsis. Catastrophic. See, remember, when the cause is precipitated by MI, hemorrhage, uncontrolled bacterial sepsis, it is catastrophic. It is a catastrophe. Once a patient enters the ER, the emergency room, all of us have to get up because there is an MI or there is severe hemorrhage. The hemorrhage has to be stopped. MI has to be treated. Bacterial sepsis immediately has to be put on broad spectrum antibiotics. And this is catastrophic because the patient is going to lead into multi organ failure. And this worsens the problem. Whereas when there is age, let us look at the age of the patients and the type of shock. If there are 80 to 90% of young and patients with only hypovolemic shock, they recover with proper management. If the patients are young, usually when somebody comes and tells us, or a cousin's son or a cousin got sick, got cancer, got this, got that, we say age is on his side. Okay, he will recover, don't worry. But here, if there is only hypovolemic shock, maybe diabetes, vomitings and diarrhea, what can we do? We can immediately infuse him with lot of fluids. Okay, they recover. 75% of the patients with MI and gram-negative sepsis die even with the best medical care. Even with the best medical care you're giving them, 75% of the patients die. Okay. So I end this class with a quote again. Chances of success. Always keep talking about success. What is success? Success is nothing but passing this exam, this temporary goal and a permanent goal. Temporary goal would be passing every year, every subject. Permanent goal would be to become a good human being, along with lots of lifelong learning. So, chance of success are 0% if you say, I won't. See, I won't is different from I can't. I won't is you're reluctant to try something. 10% I can't. Yes, you can still do it. 20% you feel, yes, I want to do it, but I don't know how to. 30% I wish I could. Here, the person is feeling, oh, maybe I should do it, but I wish I could do it. 40% there is some motivation here. He wants to do it. 50% he's halfway through and he thinks I might. 60% I might succeed. I might do this job. I might pass in the exam. I might write the exam. 70% I think I can. 80% I can. No thinking. Here he's I can do it. 90% I am succeeding. 100% when he's finished the task and he says, yes, I did it. Okay. This term which I say, I did it. Even the children, they do a small a task and they play some games and they say, I did it. I did it. The satisfaction which comes of saying I did it is immense. Okay. This has to be your attitude towards your exam. So, what I suggest is you have three subjects. Okay. Pathology, microbiology, and pharmacology. So, pathology, being a pathologist, I would always say pathology is important, and a microbiologist would say microbiology is important, pharmacology would say pharmacology is important. But pathology, it applies to all the subjects. Okay. Medicine, if you have to learn, yes, pharmacology, micro also, but pathology is there everywhere, all the subjects, all the topics. So, every day, 1 hour, you concentrate on reading each subject. So I'm not going to say read 3 hours for pathology. Read 1 hour each. 1 hour for pathology, 1 hour for microbiology, 1 hour for pharmacology. Okay. And what do you do on a holiday? On holidays, you try to multiply by 2 or 3. Okay, 7 hours sleep is enough. Okay, not more than that. More than that, you will start becoming lazy and procrastinating and delaying things. So, on a holiday and vacation, see that you read at least 2 hours or 3 hours per subject. Okay, this should be a goal. You may ask me, ma'am, tomorrow if I have exam, how can I read all three subjects 1 hour, 1 hour? No, tomorrow suppose you have pharmacology exam. Okay, today you sit and read these 3 hours for pharmacology, and tomorrow you can compensate for the extra work you have put in. So because success is not a, it's not a choice or it's not a luck. Luck will always favor you when you do hard work. And when you're steadily climbing up every day, you have to read and then you can do the portion. So, as I always tell in my classes, finish reading the book. And usually we tell our postgraduates by the time you go for the examination, Robbins, you should have read at least 5 times. Because looking at the books, I can make out how many times the books have been read by the students. Okay, so when you have read it thoroughly, when you have underlined, you mark, you fold the pages, it doesn't matter. The book should look as if it has been read thoroughly. Okay, only then, yes, you will have the confidence. Yes, I have read well. When you have read well, you have the confidence that you have done it the maximum. You have given your maximum. Reading is not only the thing; you also have to remember, retain, and you also have to write in your examination. So some students come to me and say, ma'am, we don't have good handwriting because maybe my parents and the teachers didn't concentrate on them to have a good handwriting. So how can you go have a good handwriting now? So my postgraduates, I tell them, buy cursive writing books. I think you all know what a cursive writing books. So buy a cursive writing book. There is a saying in English which say, mind your P and Qs. What is this P's and Qs? So you have to learn to write in a straight line. You have to write, give prolongation to your P and the Q and the L. So as a whole, on the whole, your handwriting should look palatable to everybody. Tomorrow, you should not be ashamed of your handwriting. Okay? You should be able to read what you have written. There are instances where the students were asked to read what they had written in the internal examination and they can hardly read it. And how can an examiner read what you have written unless if you alone can't read it? Okay? So, try to write at least 5 pages every day till you feel that you have mastered a little. And in the exam, try not to strike what you have written because it becomes clumsy. As soon as you get a question paper, you have to 5 minutes or 10 minutes give some time for the question paper, go through it, scan it, and then you can't write anything on the first page or the question paper. So the last page is given for your rough work. Okay. I have a habit of the minute see a question, I get some thoughts in my mind. So I would just pen them down on the last page. Okay. So suppose when you're writing the exam, you're not able to recollect the term. Then what you do is you go back to the rough page and then, okay, oh, this is a definition, this is a classification, and these are the special strains. That's how you have to write. Okay. And try to finish off 5 minutes before because sometimes what happens is you may have missed a question, and in the last minute, when the paper is being taken away, you will remember that you have not attempted the question. It doesn't happen very frequently, but it happens. So, last 5 minutes, give yourself time to finish the sketches, the figures, and the flow charts. The figures have to be labeled. And again, one more point I would suggest is when you're drawing the figures, try to draw them with the color pencils only, sketches or color pencils, so that you don't waste time. Some students, what they do, they draw in black and white, and then they feel that they can sketch. When we are correcting papers, some students I have seen beautiful pictures with labeling and shading, even shading they do. I don't know how they do it because all the questions have to be answered. And one more very important point is leave no question unanswered. This is the dictum for your life. Whenever you're writing an exam, you have to answer all the questions. Because if you don't answer a question, what do we say? We write not attempted, NA. Okay. If it is very wrong, it is not at all pertinent, then we write it is incorrect. But most of the time, when you write something, you get at least half mark. So if suppose you're not knowing four shots, you're writing something, you're getting half, you will get 2 marks. If you don't write anything, you're going to get zero, not attempted, and zero. Okay. Please take care about what you're writing in the theory and how we are managing your records. Okay. Always I tell my students cover up your records because they're important and they have to be taken care of. Otherwise, you will lose them and you will not have anything to read just before the examination. Okay. So let us meet tomorrow. We'll be discussing one more topic tomorrow. Okay. Oh, rather timer, I think we have. No, yes, no, yes. Last end, so we're going to have five. Right there. 2 minutes of personal life.